Yeah, good evening, and many thanks to the organizers for inviting me to give this talk today. And over the next 15 minutes or so, the mandate given to me is to talk about the IMpower 133 study, which actually established Tecentriq plus chemotherapy in first-line extensive stage small cell lung cancer as the standard of care. So these are the various aspects that I'll try and cover in my talk. So I'll briefly talk about small cell lung cancer, its incidence, prevalence, the treatment guidelines, the various options, how treatment has had an unmet need for a significant amount of time, and how the advent of immunotherapy and particularly atezolizumab is actually to a large extent changed outcomes, improved outcomes for these patients. So we all know that small cell lung cancer is a very fast growing tumor. Doubling time is nearly 2 months. Overall response rates can be very high to first line therapy, but there are very limited second line options. Patients can develop early metastasis. In fact, 72% of patients present with metastatic disease. Mean age is high at 65 years, and significant number of patients present with tumor-related symptoms. Majority of these patients are smokers, and unfortunately, despite the advances in lung cancer overall, there are no targeted therapies as yet in small cell lung cancer. Now, small cell lung cancer accounts for about 13 to 15% of all lung cancers. The 5-year survival rates are very dismal at around 2%. So how do we stage small cell lung cancer? I think the traditional classification has been the Veterans Affairs lung cancer classification, and they have typically divided small cell lung cancer into small stage, the limited stage or extensive stage. Limited stage refers to patients who can be treated with radiation therapy, where the disease is actually encompassable in one radiation field, and then the extensive stage disease, where the disease is not confined to one area which can be encompassed in a radiation field, and therefore is typically treated with systemic chemotherapy. Now, majority of patients, as I said earlier, even in the West, present with extensive stage disease. So nearly 2/3 of Western patients with small cell lung cancer present with extensive stage disease. And we talk about Indian data. I think nearly 3/4 of our patients present with extensive stage disease. So what are the treatment options? As I said, for limited stage disease, predominantly the treatment options are concurrent chemotherapy along with radiation therapy. For the isolated few patients who had node negative disease, very small primaries, surgery may be an option, but most of these patients end up receiving adjuvant chemotherapy and radiation therapy if node positive. For extensive stage disease, for a long period of time, platinum-based chemotherapy has been the standard of care. Most of these patients would end up receiving PCI to the brain, even in the absence of brain mets, because it has been shown to, at least based on the older studies, to improve overall survival. Now, the problem with small cell lung cancer has been the minimal progress that has been made in the treatment landscape. And I think since 1990s, the standard of care has been platinum etoposide. So most of the clinicians have used cisplatin or carboplatin with etoposide based on the data to show that the two drugs combined together work better than a single drug. The data also showed that the older formulations of CAV, that is cyclophosphamide, anthracycline, and vincristine, carbo-etover or cis-etover, nearly equivalent in terms of response rates. There has been a lot of interest around adding more agents, but unfortunately 3 or 4 drug regimens have failed to add to benefit. Maintenance chemotherapy has failed to add benefit. There has been some studies, particularly the JCOG study, which actually looked at cisplatin irinotecan, which while initially did reveal that there was some advantage, later on in the Western studies, at least, it showed that the regimen was probably as good as platinum etoposide, not better. What about refractory? I think, again, dismal outcomes with various agents that are used, including the irinotecan, docetaxel, gemcitabine, etc., etc. So clearly, when we talk about small cell lung cancer, and particularly in India, it's a systemic disease, majority of patients presenting with advanced stages. And for most of us, a platinum etoposide is the standard first line option. I feel most of us would be starting carboplatin etoposide rather than cisplatin etoposide. And a very small number of patients in India would actually receive a platinum irinotecan in the first line setting. Outcomes or results in India, I think fairly dismal. While we look at the analysis from the Western countries, 5-year outcomes are to the tune of 10-11%. Unfortunately, the Indian scenario, the 5-year survival rate are less than 5%, and there are hardly any patients who survive, go on to live for 5 years. As I said earlier, while chemo works well in terms of responses, and majority of patients would have a response to first line therapy, the median PFS is dismal. And if you look at data from single centers, probably as high as 6 months, but I think in my own personal experience, probably as low as 4 or 5 months. Median OS is also 10 months are standard. Counseling of our patients is that the median survival is about 10 to 12 months for most patients who present with this disease, and hardly any of these will go on to live for 5 years. So the major challenge clearly has been how to improve outcomes. Now, immunotherapy has led to some improvement in outcomes in non-small cell lung cancer, and clearly there was a lot of interest in exploring immunotherapy in this setting as well. We've had various drugs which have been evaluated. We've had the evaluation with atezolizumab in the IMpower 133 that I'm going to talk about. Other monotherapies like pembrolizumab have been evaluated, some PFS advantage, no OS advantage, and there's also been an interest around nivolumab, ipilimumab, again failing to show a significant advantage. There's a lot of sense in combining immunotherapy with chemotherapy. We know that the combination will work well. We know that chemotherapy will lead to release of cancer antigens, lead to higher presentation of the cancer antigens, lead to priming and activation, which would actually make the tumor more immunogenic, and therefore will actually enhance the benefit of immunotherapy. And so there's a lot of sense in combining the two, but we've been waiting for more data to show that the combination actually works in the patient setting. So this was the rationale of IMpower 133. Looking at the dismal outcomes with the previously existing regimens, the idea was to how to improve outcomes, and the goal was to combine immunotherapy with chemotherapy to try and see if a more favorable environment could be created within the tumor to maximize the potential of the immune system to eliminate the cancer cell. So this was the schema. So patients who were eligible had to be extensive stage small cell lung cancer, had to be chemo naive, ECOG PS01, stratified based on sex, performance status, and presence or absence of brain mets, randomized 1:1 to 4 cycles of carboplatin etoposide with or without atezolizumab at 1200 mg once every 3 weeks. Those patients who had a partial response or at least a stable disease could go on to receive maintenance atezolizumab, while those who were on the chemo alone arm would receive a placebo. And the co-primary endpoints were investigator-assessed PFS and overall survival, whereas the secondary endpoints included overall response rate, duration of response, 6 and 12-month PFS, 12 and 24 months OS, and the TTD in patient-reported lung cancer symptoms. So PCI was permitted at the end of chemotherapy. We know in our usual clinical practice, PCI is often considered, and so this was allowed. Consolidative radiation therapy to the thoracic disease, while has been used in select patients with extensive stage lung cancer, was not allowed. And while it is considered, it was not considered as the standard of care, and therefore was not allowed in this trial. What about the choice of chemo regimen? So while there was initially some criticism as to why carboplatin was used, we know that there are 4 trials which have actually compared carboplatin with along with etoposide versus cis-in-eto, and a large meta-analysis of all these 4 trials went on to reveal that the outcomes in terms of median PFS, median OS, and overall response is actually equivalent or nearly equivalent with carboplatin etoposide versus cisplatin etoposide. And we know that carboplatin has lower renal, neurological, and GI toxicity, while it may have some higher hematological toxicity, and therefore for most of our patients in real-world setting as well, the go-to regimen in extensive stage small cell disease is carboplatin etoposide. So what were the results? So these were the endpoints, as we have earlier discussed, co-primary endpoints, PFS and OS. And so what were the results? So this was the population. The median age in both the arms was about 65 years. Most of the patients, 2/3 were males. Most of the patients were either current or former smokers. There was a significant number of Asian patients as well. Most of the patients had ECOG PS of 1. A very small number of patients had brain mets at baseline, about 8% and 9% respectively. I believe majority of patients with brain mets would have worse PS and therefore may not be eligible for the clinical trial. So how did the results pan out? So when you look at overall survival, which remember was the primary endpoint, OS was significantly improved with atezolizumab when added to platinum etoposide-based chemotherapy. So median OS was improved from 10.3 months to 12.3 months. This was a 30% reduction in risk of death at milestone of 12 months. While in the chemo alone arm, 38.2% patients were alive. This figure improved to 51.7% for the chemo immuno arm with atezolizumab. And therefore, this is a significant improvement in the overall survival of the atezo chemo arm population of patient. In fact, when you look at the updated OS, so when you look at OS at 18 months, so that's another milestone analysis. The median, about 21% of patients in the chemo alone arm were alive in this trial, whereas when you look at the population of patients who received atezolizumab and chemotherapy, the number was 34%. So the delta was about 13% at 18 months. So 13% higher number of patients alive in the chemo immuno arm, and 3 times as many ongoing responses were seen with the immunotherapy arm compared to the only chemo arm. What about PFS? The investigator assessed PFS was also improved by the addition of atezolizumab to chemotherapy. The hazard ratio was 0.77. And when you look at overall response rates were fairly similar in the two arms at about 64% for CR and PR versus 60% for the chemoimmunotherapy arm. So subset analysis, fairly homogeneous results across various subsets. Clearly, what was coming out was that the tumor mutational burden or PDL1 expression did not, affect the outcomes in any way. I think what's slightly interesting is that the small limited number of brain mets patient, the confidence intervals appear fairly wide. But again, numbers were very small, and therefore, overall, the addition of atezolizumab improved outcomes in most subsets of patients, as seen in this trial. So did the addition actually affect the tolerability of platinum etoposide? Clearly, the data says no. When you look at the treatment-related grade 3-4 adverse events, 67% versus 63% in the atezo versus chemo alone arm. Majority of patients were able to complete all planned chemotherapy. When you look at the number of patients having serious adverse events, so slightly higher at 39% in the atezo chemo arm versus 35, but not a major difference. And again, adverse events leading to withdrawal, about 11% in the atezo chemo arm versus 2.6 in the chemo alone arm. So this study could be summarized that the addition of atezolizumab actually clinically and meaningfully in patients with extensive small cell lung cancer. In fact, this is one of the first studies in more than 20 years which has led to an improvement. There's also a median improvement in median PFS. Hazard ratio was sitting fairly impressively at 0.7 for OS and 0.77 PFS. And in fact, at 12-month OS, there was a delta of 13.5% with more than 13.5% or greater improvement in outcomes with atezo chemo versus chemo alone. So not surprisingly, most international guidelines acknowledge the improvement in outcomes, and both NCCN and the European Medicines Agency actually now recommends the combination of atezolizumab with carboplatin etoposide for treatment of first-line patient with extensive stage small cell lung cancer. And these are the general treatment guidelines. So I'll quickly summarize and say that IMpower 133 is the first positive trial of an immunotherapy drug when added to chemotherapy combination for first-line extensive stage small cell lung cancer. The combination of atezo, carbo, eto is a major advance. And in fact, in 20 years, we have not had any meaningful improvement until we had this study. Based on the results, it is now recommended by NCCN, ESPO, and other key treatment guidelines for patient treatment in the first-line setting. The study demonstrated superior survival benefit with the addition of atezolizumab, with a median OS of 12.3 months for chemoimmuno versus 10.3 months for the chemotherapy alone arm. And 52% patients were alive at 1 year in the chemoimmuno arm versus only 38% for the chemo alone arm. And in fact, now we have other studies which are looking at all-comer population, regardless of biomarker status, to see whether we can shed more light to the data. Thank you very much for your patient hearing. And with that, I hand back the stage to the organizers. Thank you once again.